Imagine buying an incredibly expensive, cutting-edge medical treatment. You place your absolute trust in those glossy brochures, the high-end clinics, the confident doctors.
Right, you're buying into a whole promise of rejuvenation.
Exactly. And then, maybe years later, you find out that the people who got a completely fake version of that exact same treatment got the exact same results as you.
It's a pretty terrifying realization.
There really is. So today we're doing a deep dive into the exploding multi-million-dollar industry of vaginal rejuvenation. And specifically, we're looking at the massive gap between how fast medical marketing moves and how incredibly slowly the actual science catches up.
Because the marketing is just, it's sprinting at 200 miles an hour, promising miracle cures, while the rigorous clinical science is basically still lacing up its shoes at the starting line.
Yeah, and that gap is precarious for anyone trying to navigate the healthcare system today, which is why we've put together a really fascinating stack of sources for this deep dive.
You've got a lot to cover.
We do. We're looking at FDA safety communications, a massive double-blind randomized clinical trial published in JAMA, clinical consensus statements from the American Urogynecologic Society.
And we also have the direct pushback from the clinics themselves, the ones defending these procedures. Plus, the rigorous medical ethics guidelines from the General Medical Council in the UK.
Right, because our mission today isn't just to talk about, the biology of lasers. We're aiming to answer a much more crucial question for you, the patient.
Yeah, when the medical evidence surrounding a device is wildly uncertain, how exactly are clinics supposed to explain that uncertainty to you without crossing major ethical lines?
Okay, let's unpack this, because we're navigating a real maze of biology, regulations, and ethics here.
It's a lot to untangle.
For sure. So to even understand the controversy, we need to establish the baseline. What exactly are these devices doing to the human body?
Well, we're talking about energy-based devices, or EBDs. In this specific context, these primarily include fractional CO2 lasers, ERYAG lasers, and radiofrequency devices.
Wait, let's pause there for a second. CO2 I have definitely heard of, but what is ERYAG? Is that like just a different wavelength of light or a totally different type of laser?
It's a specific type of solid-state laser. It uses a different crystal and emits a different wavelength of light compared to a standard CO2 laser.
Okay, got it.
The theory is that it targets the water in the tissue slightly differently. But honestly, the end goal of all these devices is essentially the exact same thing, which is thermal ablation.
Meaning they burn it.
Basically, yeah. The device heats the vaginal tissue to somewhere between 45 and 60 degrees Celsius.
Wow. Okay, for context, 60 degrees Celsius is about 140 degrees Fahrenheit.
Right.
That's hot enough to cause a severe third-degree burn if you just expose your skin to water at that temperature for a few seconds. So we're talking about delivering serious, intense heat directly into highly sensitive tissue.
We are. And the medical rationale they use is that by inflicting this controlled thermal damage, you actually trigger the body's natural healing cascade.
So you hurt it to heal it.
Exactly. The goal is to stimulate the production of new collagen, elastin, and new blood vessels deep in the vaginal submucosa, which is, the layer of connective tissue right beneath the surface lining.
And what exactly is the target condition here? Like, why would someone actively seek out a controlled burn in that specific area?
Well, these devices are heavily marketed to treat a condition called genitourinary syndrome of menopause, or GSM.
Okay.
And that's an umbrella term that includes severe, debilitating vaginal dryness, intense pain during sex, which is known clinically as dyspareunia, and general vaginal laxity.
So on paper, the marketing pitch sounds like a technological miracle for conditions that cause a tremendous amount of silent suffering.
It sounds incredibly appealing, yes.
But here is where the massive clash happens in our sources. On one side of the aisle, you have clinics aggressively defending these treatments.
They're not backing down.
Not at all. For example, the Women's Health Clinic in the UK pushed back hard against regulatory warnings. They argue that CO2 lasers have a 35-year safety record in treating other areas of the body, like the face and neck.
Yeah, that's their main defense.
And they explicitly state that because the heat generated doesn't go beyond 60 degrees Celsius, the possibility of severe thermal damage is practically illusory.
Illusory, that's a strong word.
Very strong. In their view, if a patient has a bad outcome, it's the fault of an undertrained practitioner holding the laser, not the laser itself.
But then you look at the other side of the aisle, and the picture couldn't be more different.
It's night and day.
It really is.
Yeah.
Major regulatory bodies worldwide, the FDA in the US, NICES in the UK, the TGA in Australia,
Right.
have all issued severe, highly coordinated warnings.
Right.
The FDA actually went on the record explicitly stating that the safety and effectiveness of these energy-based devices for vaginal rejuvenation or treating menopause symptoms simply has not been established.
They are essentially telling the public that this is entirely experimental territory.
Exactly.
I have to push back on the clinic's claim about that 35-year safety record, though. Wait, they're using safety data from treating the skin on people's faces or necks and just blindly applying it to internal vaginal tissue.
That is exactly what they're doing.
That feels like taking a tractor engine that has run perfectly in a field for decades, bolting it onto a commercial airplane and saying, well, the engine has a great safety record.
That analogy hits the nail on the head.
I mean, the environment, the tissue, the physiological stakes, they're entirely different.
You cannot simply grandfather in SACI data from a completely different organ system and just declare a new procedure safe. The tissue architecture, the blood flow, the nerve endings, they all react entirely differently to thermal injury.
Which brings us to one of the most illuminating data points from our sources.
Yes, the 2021 Australian randomized clinical trial.
Published in the Journal of the American Medical Association, led by Lai and colleagues. This study is the definition of a massive aha moment.
It really is a landmark piece of research, mostly because of just how rigorous it was.
Yeah.
It was a double-blind trial involving 85 postmenopausal women who were suffering from really bothersome vaginal symptoms.
Okay.
And the researchers split them into two groups. One group received the actual fractional CO2 laser treatment. The other group received a completely sham or placebo treatment.
A fake laser treatment is just a wild concept to wrap your head around. Like, how do you even fake that?
Well, they used a low setting on the machine that had absolutely no physiological tissue effect.
Oh, wow.
But to maintain the illusion, they still applied the local anesthesia cream. They went through all the clinical motions.
They really committed to the bit.
Oh, they even used a plume evacuator to mimic the loud sound and the smell of the laser smoke, so the patients wouldn't have a clue which group they were actually in.
That is incredible. The methodology was incredibly thorough.
Which is exactly what makes the results so undeniable. After 12 months of tracking these women, there was absolutely no significant difference in symptom severity between the group that got the real laser and the group that got the fake laser.
None at all. And to make matters more complicated, many women in both groups reported that their symptoms actually improved over time.
Which highlights a massive textbook placebo effect.
So interesting.
It turns out that the very act of going to a medical clinic, receiving dedicated attention from a doctor, and undergoing a highly ritualized, expensive-feeling technological procedure made these women feel physically better.
The ritual itself was the treatment.
Exactly. Regardless of whether the laser actually burned the submucosal tissue or not.
Okay, so if a fake laser makes people feel better, I think the obvious question is, who cares? Let them have the placebo.
Right, what's that harm?
Yeah, if the ritual of putting on a paper gown and hearing a machine hum relieves someone's chronic pain, why are the FDA and the urogynecologists stepping in to stop it?
Well, if we connect this to the bigger picture, the answer is that this isn't just a harmless sugar pill. The placebo might be effective for some, but the physical delivery mechanism carries very real, very severe dangers. We have to look at the actual physical and psychological stakes for the patient.
Let's look at that physical reality first, because the FDA logs paint a pretty grim picture.
They really do. A 2019 analysis of the FDA's MAE database, that's the federal system that tracks medical device reports and adverse events, revealed some severe, life-altering complications linked directly to these vaginal lasers.
We aren't just talking about mild discomfort here.
No, not at all. The reports detail severe vaginal burns, extensive internal scarring, hyperpigmentation, and chronic, unrelenting pain.
That's horrifying.
And in some of these cases, the painful intercourse that the patient was originally trying to cure actually became much worse and permanent after the procedure.
So you go in hoping to cure your pain, dropping thousands of dollars on a promised miracle, and you leave with severe burns and worsening chronic pain. That is a devastating physical stake.
It's the worst case scenario.
But our sources also highlight an intensely fraught psychological reality here, too.
Right.
Who is the typical patient actually seeking out these treatments?
The demographics here are crucial to understanding the ethical dilemma. Many of the patients seeking out these energy-based devices are postmenopausal women, or very frequently, breast cancer survivors.
Oh, that makes sense.
Right, because breast cancer treatments often plunge women into early, medically induced, and very severe menopause.
Yeah.
And because their specific type of cancer might be hormone receptor positive, they're usually strictly forbidden by their oncologists from using traditional localized estrogen creams, because the estrogen could potentially feed the cancer.
Wow. So they're dealing with severe pain, their standard medical options are basically stripped away, and they are desperately scouring the internet looking for any kind of relief. They're incredibly vulnerable.
What's fascinating here is how the top medical regulators respond to that exact specific vulnerability.
Yeah.
Well, if you read through the General Medical Council's ethical guidelines for cosmetic and aesthetic practice, they do not treat this like a standard commercial transaction.
Good.
Because the stakes and the vulnerabilities are so high, the guidelines explicitly mandate that clinics must actively screen their patients for psychological vulnerabilities before ever turning on a laser.
I'm guessing that means they can't just hand you a waiver on a clipboard in the waiting room. How do they actually screen for that?
The doctor has to conduct a thorough assessment to see if the patient has unrealistic expectations about the outcome.
Expectations that clearly cannot be met by the actual physics of the device.
Exactly. And they are required to look into the patient's medical history for a pattern of repeated cosmetic procedures, especially in one anatomical area where the patient is perpetually dissatisfied.
Oh, looking for signs of body dysmorphia.
Right. If the doctor spots these red flags or notices a history of coexisting psychological disturbances, the ethical guidelines state they should halt the process immediately.
Just stop the consultation.
Yes. And refer the patient to a qualified mental health expert before moving forward with any physical procedure.
Okay, I'm going to play devil's advocate for a second.
Go for it.
Doesn't that sound incredibly
When you combine severe chronic physical pain with targeted Instagram ads promising a miracle cure, the line of what constitutes undue pressure gets heavily blurred. The psychological screening is a necessary safety net to ensure that a patient isn't being financially or physically exploited in a moment of sheer desperation.
So it's about protecting the integrity of the decision itself, ensuring the patient is actually in the driver's seat.
Precisely.
Which brings us to the core mission of our deep dive today. How exactly must a clinic communicate this messy, complicated web of sham trial results, FDA warnings, and burn risks to you, the patient, while you are sitting in the consultation room?
Well, the rules here are uncompromising, and it all starts with who is actually doing the talking. The GMC enforces a strict rule of non-delegable consent.
Meaning the clinic can't just pass the buck to the receptionist.
Right. If a specific doctor is going to perform or clinically supervise the laser procedure, that exact doctor must personally seek your consent.
That makes sense.
They cannot delegate this crucial conversation to junior medical staff, a triage nurse, or, a slick clinic salesperson.
That immediately eliminates the whole pressure cooker sales tactic, where a smooth-talking patient coordinator sells you on the dream in a plush office, and you only meet the actual doctor 5 minutes before the procedure when you're already in the paper gown.
That practice is strictly forbidden under these guidelines. And during that required one-on-one conversation, the doctor cannot just lazily read off a list of physical risks like, oh, it may cause scarring or burns.
They have to go deeper.
The cosmetic practice standards mandate that the doctor must provide a thorough explanation of the quality of evidence that exists for the proposed procedure.
Here's where it gets really interesting. Put yourself in that consultation chair for a second. Think about how wild that mandate is compared to almost any other consumer experience. Imagine going to buy a brand new, expensive car, and the salesperson is legally required to look you in the eye and say, by the way, the highest quality double-blind study we have shows this car's engine might just be a placebo, and the major federal regulatory bodies consider driving it to be experimental and potentially dangerous.
It's a crazy thought experiment.
That is what true informed medical consent requires in this scenario. They have to actively admit to you that the science is shaky.
They absolutely do. It completely changes the power dynamic in the room. And the requirements don't stop there.
What else?
The doctor must also openly and clearly tell you about alternative interventions that carry less risk. They are required to discuss the standard evidence-based treatments before offering their experimental laser.
So they have to offer alternatives. I'm guessing that means pointing them toward things like traditional localized estrogen therapies for those who can take them.
Exactly.
Or maybe over-the-counter moisturizers and physical therapy.
That's exactly the protocol. Depending on the patient's specific medical history, they must discuss vaginal estrogen, specialized lubricants, or pelvic floor physiotherapy. And crucially, they must offer and discuss the option of doing nothing at all.
Wow, they really have to present the full, unbiased menu of options, not just the expensive proprietary laser they have sitting down the hall.
They have to give you the whole picture.
So let's follow the timeline here. You've had that intense, eye-opening conversation. The doctor has explained the JAMA sham trial, the severe FDA warnings, the alternative therapies, and the risks of scarring. What happens next? Do you just sign on the dotted line right then and there?
You shouldn't. Transitioning from the heavy consultation to the actual decision-making phase, the GMC mandates what is effectively a cooling-off period.
The cooling off period.
Yeah, patients must be given adequate time and written information to go home and reflect before deciding.
Why is a cooling off period physiologically or psychologically necessary? Why isn't a signature on a consent form enough?
Because being in a clinical environment, listening to an authority figure in a white coat, it can be hypnotic,
Yeah.
especially when you are desperate for a cure.
Oh, for sure. You just want to say yes to whatever they suggest.
Right. The cooling off period breaks that spell. It gives the rational side of the brain time to catch up, process all those heavy warnings about the lack of evidence, and weigh the alternatives away from the subtle pressure of the clinic environment.
That makes a lot of sense.
The principle is that consent is never a one-off event. Clinics must explicitly tell you that you can change your mind at literally any point, even right up to the moment the laser is being turned on.
And what happens if you go through the cooling off period, you consent, you get the procedure, and those uncertain risks become your reality? What if you are one of the women in the Myote database who ends up with a severe burn or worsening chronic pain?
This is where the cosmetic standards dictate a strict duty of candor.
Duty of candor.
Yes. The medical profession demands zero cover-ups. If an outcome is less favorable than expected, or if a severe complication occurs, the clinic must proactively provide you with an open, honest, and documented explanation of exactly what went wrong.
So they can't just brush you off, tell you you're crazy, or say, oh, that's just normal post-op swelling.
No, gaslighting the patient is an ethical violation. Furthermore, under the duty of candor, they must instruct you on exactly how to report those adverse reactions to the relevant independent regulators.
Like the MHRA in the UK or the FDA in the US.
Exactly. They essentially have to help you report their own failure to the authorities.
Wow. Okay, I've one final scenario for you, and I think it's the trickiest one ethically.
Lay it on me.
Let's say a patient has heard all the warnings. She completely understands the sham trial data. She knows the risks of permanent scarring, but she is in so much psychological and physical distress, she absolutely insists on getting the laser treatment. She has the money, she has passed the cooling off period, and she is ready to go. But the doctor, looking at her specific medical history and the lack of evidence, genuinely thinks is a bad idea and won't help her. What happens then?
The ethical guidelines are unequivocal on this specific conflict. If the doctor believes the intervention is unlikely to deliver the desired outcome or be of overall benefit to the patient, they must refuse to provide it, period.
Even if the patient gets angry and threatens to just take her thousands of dollars to a less scrupulous clinic down the street.
Even then, the doctor must gracefully respect your right to seek a second opinion elsewhere, but they cannot perform a procedure they deem scientifically unsafe or ineffective just to keep the business or appease the patient.
Right.
A doctor's primary overarching duty is to do no harm, not to simply make a sale or act as a vending machine for medical devices.
So what does this all mean? We have gone from the wild west of energy-based device marketing, where glossy ads promise the fountain of youth, to the sobering, complex reality of double-blind clinical trials where fake lasers work just as well as real ones.
It's been quite a journey.
And finally, to the strict, uncompromising ethical rulebook that doctors must follow to keep you safe, informed, and protected from exploitation.
It means that in modern medicine, intimately knowing the limits of a new technology is just as important as the technology itself. We live in an era where medical innovation is accelerating incredibly fast.
Much faster than the science.
Faster than careful 10-year clinical trials can ever hope to keep up with, yeah.
Which means, as patients, we are going to be living and making healthcare decisions in a constant state of uncertainty.
And that reality leaves us with a final thought to mull over. As this gap between rapid innovation and solid evidence continues to widen, the act of explaining uncertainty might actually become the most vital medical skill of the 21st century.
That's profound.
It asks us to consider a paradigm shift. In an age where we can Google endless miracle cures and demand access to shiny new lasers, is the most trustworthy doctor actually the one who's willing to look you in the eye, turn down your money, and say, I actually don't know if this will work?
It's a powerful thought. You want the engineer who is honest about exactly where the tracks end, not the one who just tells you to keep blindly shoveling coal into that high-speed train. Because when it comes to your body, slowing down to ask the hard questions about what we don't know isn't a delay, it's the only way to ensure you actually arrive safely.